Welcome back, everyone. This is Ahmad Radwan again with the USMLE 101 channel. Um, we um, we are starting obstetrics, section 6, um, section 6, in Master of the Boards, step 3, in page 417. I really hope that you have done pediatrics and you like the videos that I did previously. It was a long study sessions, but I hope it was beneficial. We're gonna start obstetrics, and we're gonna hope that we can do it like in one day or maybe a day and a half. But let's just see how it goes. So again, we're starting at page 417, and we are starting with the uncomplicated pregnancy. The first part is diagnosing pregnancy. So in this part, it says here that pregnancy is suggested in a patient with amenorrhea, enlargement of the uterus, and a plus urinary and plus a urinary beta HCG test. And pregnancy is confirmed with the following. The first is going to be the presence of a gestational sac, and this is seen by transvaginal ultrasound at 4 to 5 weeks, and this corresponds to a serum beta HCG level of about 1,500 milli-international unit per milliliter. The second is going to be the fetal heart motion, and this is seen by ultrasound at week 5 to 6, so we're going sequential here so far. Then the heart sounds, and we can hear it with the Doppler ultrasonography at 8 to 10 weeks, and then the fetal movements felt by the examining physician after 20 weeks. So we have 4 to 5 weeks transvaginal ultrasound, and we can see the gestational sac, heart motion at 5 to 6 weeks, heart sounds at 8 to 10 weeks, fetal movements at 20 weeks felt by the examining physician. There is a tip here that says that we should order pregnancy counseling, which means avoiding alcohol and tobacco and so on, in newly diagnosed pregnant patients via the order icon. And I think this has to do with the step 3, so we should not really worry about that in step 2 CK. On the right side, we do have a side note that says the gravidity means the number of pregnancies, and the parity means number of births with a gestational age more than 24 weeks, which means not an abortion. All right. The second part here, it says the routine prenatal screening tests. And in the first trimester, what we're going to do, we have a stem here that says a 21-year-old primary gravida, par 0, gravida 1 par 0. So she's primary gravida, presents for her first prenatal visit at 11 weeks gestation, which is confirmed by an obstetric sonogram. She has no risk factors. What screening tests will she need? To answer this question, we do have a very big table here that takes 2 pages, and it talks about the first trimester routine tests that we need to do. So we're going to start with each one, and we're going to see the diagnostic significance of each one, and the next step in management if we see anything that is abnormal. Okay, so the first thing is going to be anemia and the blood disorders. What we're going to do is a CBC, of course. The diagnostic significance is that, well, we're going to have the anemia is going to equal a hemoglobin of less than 10 gram per deciliter. The normal is going to be 10 to 12 in general, but this is where we see the abnormality here. The most reliable indicator of true anemia is the MCV. Okay. The most common cause of anemia is iron deficiency, of course. That's why we give iron in the second trimester. The white blood cell count is going to be more than 16,000. This is going to be abnormal. In pregnancy, caused by increased level of hepcidin, which inhibits iron transport. Pregnancy increases the iron demand, but hepcidin prevents the absorption. So that's why we get that problem. What is going to be our next step in management in such cases of anemia and so on? Well, if there is decrease in hemoglobin and decrease in MCV, we're going to give iron. We should test for thalassemia if the anemia does not improve with the iron. If there is decrease in hemoglobin and increase in MCV and or DW, we're going to give folate. is going to be macroscopic anemia here. And if we have thrombocytopenia, which means that we have thrombocytes less than 150,000, we're going to correlate clinically for ITP or HELP syndrome. So either ways. The second thing that we're going to screen for is going to be the blood type, RH, and antibody. We're going to screen for the type, of course, and screen the direct and indirect Coombs test to see if there is sensitivity. And the diagnostic significance here is that the RH negative mothers may become sensitized by anti-D antibodies, and this is going to lead to risk of erythroplastosis fetalis in the next pregnancy. Indirect Coombs test or atypical antibody test is going to detect atypical RBC's antibodies. So the next step in management, we're going to give RhoGAM to RH negative mothers at 28 weeks after the first screening for absence of anti-D antibodies. So that's kind of different because it's not 28 weeks gestation, it's 28 weeks after the first screening of absence of anti-D antibodies. Okay. And we're going to give RhoGAM in RH negative mothers after any procedures like CVS, amniocentesis, and after delivery. So this, I think I'm going to talk in details later on about this RH thing in later chapters here. Okay, so the third thing we're going to screen for is the genital urinary screening. We're going to have a cervical pap smear, and we're going to do a urine analysis and urine culture. Let's talk about the cervical pap smear first. This is to detect cervical dysplasia or malignancy, and we're going to see a gynecologist for that, and the gynecology section is going to have more on the cervical dysplasia and malignancy. In urine analysis, urine culture, the urine analysis here is going to screen for the underlying renal disease and infections, if there is, and the urine culture is going to screen for asymptomatic bacteriuria. So we might have it, but we're not really, we might have bacteriuria, but we're not having symptoms. What is going to be the significance in each? We're going to always treat asymptomatic bacteriuria in pregnancy, and this is to prevent the pyelonephritis, which will 30% risk when untreated. And the second thing is to give nitrofurantoin. This is before 30 weeks gestation, and cephalosporins and amoxicillin. This is going to be the treatment that we look for. Again, treatment of urine analysis and stuff like that, I think we're going to have more details on it later on. Immunization status, we're going to look for the rubella antibodies. We're going to see hepatitis B surface antigen. Let's talk about rubella here. Rubella antibody, negative rubella IgG antibodies means that there is an increased risk of primary rubella infection. What we're going to do is do not give rubella immunization in pregnancy. We talked about the immunizations before, and we said that rubella is not needed in pregnancy. We are going to immunize seronegative patients after delivery. Okay, so not in pregnancy. We're going to immunize seronegative patients after delivery. And hepatitis B surface antigen, however, the positive hepatitis B, surface antigen would indicate risk for vertical transmission of hepatitis B virus. What we're going to do is, if there is a positive hepatitis B surface antigen, we're going to order the hepatitis B E antigen, okay? And if we have the E antigen positive, this signifies a highly infectious state, and we should suspect that there is going to be a vertical transmission. And the next thing to do here is to screen for the infection of syphilis. So we're going to do a VDRL or RPR, and we're going and if we confirm a positive VDRL or RPR with a treponema specific tests, we can confirm with those, then we have a confirmation of syphilis infection. If we do have a positive confirmatory test, we're going to treat the patient with intramuscular penicillin, which is safe, and if the patient is penicillin allergic, we can desensitize the patient and then treat with penicillin. So we're not going to really use any other drug other than penicillin here. We're not going to read the erythromycin or so on. We're going to desensitize the patient and then treat it again with penicillin. All right. What else we're going to screen for? We're going to screen for the infection of HIV, and the test to do is an ELISA test for HIV. We're going to confirm a positive ELISA test here with a Western blot test, and that's going to be presence of the HIV core and envelope antigens. The next step due in management, if we confirm that, we always get consent for HIV testing. This is really important. The second is all babies born to HIV positive women will be HIV antibody positive. This is passive transport of the maternal antibodies. And positive antibodies do not indicate infection in the infant here. It just means that he's protected. The third thing to do is antiretrovirals are not contraindicated in pregnancy, so she can take antiretrovirals. What we're going to do is we're going to see the perinatal infections later on in the section, and to take a look more at HIV infections in that part. The next screening to do is going to be infection again, but with chlamydia and gonorrhea. So far, we are seeing the infections that had to do with STDs, like HIV, hepatitis B, syphilis, and now chlamydia and gonorrhea. What we're going to do is a cervical culture for both. I'm sorry. In the diagnostic significance here, we see that we're going to do a gram stain, like chlamydia and gonorrhea culture as well, and we're going to treat Trichomonas vaginalis right away, because it can cause premature labor, which is going to be a problem. The Chlamydia trichomatis here is an obligate intracellular parasite, and that means it needs a host cell to survive. And the Neisseria gonorrhea is a gram-negative diplococcus that grows on chocolate agar. And it says here that NAT and AAT is the test of choice. What are we going to do with the significance of all of this is that if we have a positive chlamydia or gonorrhea, we're going to give PO, oral erythromycin plus IM ceftriaxone, and this is the treatment of choice. So remember this one, IM ceftriaxone along with the PO erythromycin. Alternatively, we can give a amoxicillin oral. If we have positive bacterial vaginitis, we're going to have metronidazole oral or clindamycin oral. And if we have Trichomonas vaginalis, then we're going to give only metronidazole. So again, Trichomonas vaginalis, that's going to be metronidazole. Bacterial vaginitis, that's going to be metronidazole or clindamycin. If we have chlamydia or gonorrhea, the first or the treatment of choice is going to be erythromycin oral along with IM ceftriaxone. If we need an alternative, that's going to be oral amoxicillin. Okay. Now those were the routine tests. Well, how about if we have some optional tests that we can do? Well, there are two things to consider here. The tuberculosis, and that's going to be a PPD test. We're going to test for exposure to TB in high-risk mothers only, so that's why it's optional, not for everybody. And a positive test is going to be showing induration but not erythema. And the significance here is that if we have a negative PPD, we don't really need to do anything at all. But if we do have a positive PPD, we're going to order the chest X-ray, and this is to rule out active disease. We can have pulmonary TB here. If we have a positive screening at the end, the treatment is going to be different. If we have a positive PPD but negative chest X-ray, we're going to give isoniazid and B6 for 9 months. If we have a positive PPD and a positive chest X-ray, we're going to also do a sputum culture, and if it is positive, we're going to begin the triple therapy here. Anti-tuberculous drugs, and if sputum stain is positive, we're going to obtain a sputum for culture. So that's going to be that part. And the note here says also that we should avoid streptomycin in pregnancy because there is an increase of risk of ototoxicity in the fetus. So to recap, negative PPD, do nothing. Positive PPD, order the chest X-ray. If there is a positive PPD and negative chest X-ray, we're going to have isoniazid along with B6 for 9 months. If we have the positive PPD and a positive chest X-ray and a positive sputum, then we're going to begin the triple therapy of anti-tuberculous drugs. But it is important to avoid streptomycin because of the ototoxicity to the fetus as a side effect. Okay? All right. Now finally we have the trisomy 21. We can have an early testing for it. Beta HCG can be the test here, and pregnancy-associated plasma protein A, PAP A, and we can have a fetal knuckle translucency test. Both the offered to high-risk pregnancy, like a female above the age of 35 at delivery, and women with a history of prior trisomy 21, so they want to make sure that everything is okay. A positive screening test is going to be confirmed with the chorionic villus sampling in the first trimester. We can do that to confirm the diagnosis here. So that's been so far the tests that we can do, and it would be really wise to take a look at them again and remember each and single one because they are important. And I guarantee they're going to be a test, on the test, at least one question on it. Okay. So that was the first trimester here. Well, how about the second trimester? We have here a question. And the question says, a 23-year-old woman, a gravid 3, part 1, and she has 1 abortion, is seen at 17 weeks gestation. She recently underwent a triple marker screening with the maternal sputum alpha fetoprotein, which is normal. And normal is less than 2.2 MOM. Her test showed an elevation in maternal sputum alpha fetoprotein. On examination, her uterus is at the umbilicus. Now, what is the next step in management here? And the options are amniocentesis, chorionic villus sampling, inhibin A, recommendation for termination of pregnancy, or ultrasound. And of course, the answer is going to be ultrasound. And the most common cause of an abnormal maternal serum alpha fetoprotein is gestational dating error. So that's really important. We should consider that this patient has an abnormal elevation because we're not really having the correct gestational age to correlate that serum alpha fetoprotein level with. The first step is going to be evaluating any pregnancy with an abnormal alpha fetoprotein or maternal serum alpha fetoprotein is to get an obstetric ultrasound to confirm the gestational age. On a side note here that says maternal serum alpha fetoprotein increases with gestational age and is expressed in the multiples of the medians, MOM, multiples of the medians. If we have more than 2.2 multiples of the median, this is considered elevated. If it is less than 2.5, multiple elevation of the median is going to be considered normal. Inhibin A is made by the placenta during pregnancy and normally remains constant during the 15th to 18th weeks of gestation. Or pregnancy, I'm sorry. The level of inhibin A is increased in the blood of mothers of fetuses with Down syndrome. So if we have an increase in inhibin A, that would indicate that we might have a Down syndrome case. So the optional screening test, or the second trimester's optional test that we can do here, like we talked before, is going to be the triple marker screen, and the testing window is going to be 15 to 20 weeks gestation. What we're going to do is the maternal serum alpha fetoprotein, beta HCG, estriol, and we can add inhibin A in high-risk women, which would increase the sensitivity to 80%. So the triple marker is going to be the MS, the alpha fetoprotein, maternal surface, and the maternal serum alpha fetoprotein, beta HCG, estriol, and we can add inhibin A. The diagnostic significance here is going to be to never test the maternal surface alpha fetoprotein alone. It doesn't really give any indications for anything. It only has 20% sensitivity, and it can increase to 70% with the triple screen here. So alone doesn't make any sense, but with the other tests, it can increase the sensitivity to 70%. Increase in the maternal surface alpha fetoprotein, that's going to mean a neural tube defect. It could mean a ventral wall defect, a twin pregnancy, placental bleeding, renal disease, and sacrococcygeal teratoma. So those are the things that we can consider. If there is a decrease in the maternal serum alpha fetoprotein, then we can consider a trisomy 21 or a trisomy 18. And there are differences between both when we consider the triple marker here. In both, we're going to see a decrease in maternal serum alpha fetoprotein. In both, we're going to see a decrease in estriol, but in beta HCG, this is where the difference is. In trisomy 21, we're going to have an increase in beta HCG, and in trisomy 18, we're going to have a decrease in beta HCG. So those are the two differences between the trisomy 21 and the trisomy 18 when it comes to the triple marker screening. So what we're going to do in terms of management here, what's the next step? Well, first, if we have an abnormal maternal serum alpha fetoprotein, the first step in management is to perform an ultrasound to confirm the dating, so we would know that it is normal. The second, if dating error, we're going to repeat the maternal serum alpha fetoprotein at the right time, and a normal repeat is reassuring at that time. We should know that accurate gestational dating is needed for interpretation of the results here, okay? The second, dates confirmed by ultrasound here. What's going to be the next step here? Well, if there's an increase in the alpha fetoprotein here, we're going to do an amniocentesis for the amniotic fluid alpha fetoprotein level and acetylcholinesterase level. For a decrease in alpha fetoprotein, we're going to have amniocentesis for karyotyping because we're going to suspect a trisomy either 18 or 21. It should be noted that elevated levels of amniotic fluid acetylcholinesterase activities are specific to an open neural tube defect. That's why we get the acetylcholinesterase activity along with the amniocentesis for the amniotic alpha fetoprotein. Okay. So that's been the second trimester. Let's talk about the third trimester here. And in third trimester, we have a question as well. And the question says, a 38-year-old woman, gravid 2-1 again, and is at 27 weeks gestation. She weighs 227 pounds. She has gained 30 pounds during her pregnancy, but reports that most of this is fluid retention. She was diagnosed with gestational diabetes during her last pregnancy. Which of the following is the next step in management? Are we going to begin insulin therapy here? Are we going to begin glipizide therapy? Obtain 1 hour 50 gram oral glucose tolerance test, or a 3 hour 75 gram the oral glucose tolerance test, or obtain a 3 hour 100 gram one. And in pregnancy, and that's just what I remember from before, what we're going to do is to obtain 1 hour 50 gram the oral glucose tolerance test, and this is actually the right answer, it's C. The first step is to in evaluating I'm sorry. So the answer was C. The first step in evaluating gestational diabetes is with the 1 hour 50 gram oral glucose tolerance test, and it's going to be in weeks 24 to 28. When it is positive, the patient must then undergo the confirmatory 3 hour 100 gram oral glucose tolerance test. So the first one is the 1 hour, and then the 3 hour 100 gram, not the 75, 100 gram. Okay. So what are the routine tests to do for the third trimester? Again, the diabetes here, in diabetes, we're going to do a 1 hour 50 gram OGTT, and this is given between 24 and 28 weeks. The abnormal result, we're going to do 1 hour glucose. We're going to see a 1 hour blood glucose of more than 140 gram per deciliter. And if we have a positive screening, we're going to perform the 3 hour 100 gram OGTT, and this is the definitive test for glucose intolerance in pregnancy. And this is going to requires an overnight fasting here to make an accurate test. The second one to do is anemia. We're going to screen for anemia. We're going to do a CBC at 24 to 28 again, gestation. And if hemoglobin is less than 10 gram per deciliter, that's going to be anemia. And the most common cause is iron deficiency again, even if not present in the first trimester. What we're going to do is going to give iron supplementation for the iron deficiency, of course. We're going also to screen next for atypical antibodies using indirect Coombs test. We're going to this is performed in the Rh negative women to look for atypical antibodies before giving the ROGAM. RhoGAM here is not indicated in Rh negative women who have developed anti-D antibodies, because it doesn't really make any sense. We already had that. So the RhoGAM is preventive rather than curative. If we do anti-D antibodies, that's just it. So finally, GPS screening. What we're going to do, GPS is the group B Streptococcus. What we're going to do is the vaginal and rectal culture for group B strep at 35 to 37 weeks. It's important to remember the 35 to 37 weeks, because that's gonna indicate if whether we're going to give treatment or not during the delivery. If we have a diagnostic test here that is positive, this means a high risk for sepsis in the newborn. We're going to treat with intrapartum IV antibiotics. The antibiotics are going to be IV penicillin G and IV clindamycin or erythromycin in a patient who is sensitive or allergic to penicillin. So that's been the screening for the trimester here. The third trimester screening or routine test: diabetes, anemia, atypical antibodies, and group B strep screening. The final thing here before we go away in this session is to talk about gestational diabetes, like we talked in the previous question. It says here that it does not present with typical symptoms of diabetes. Actually, the vast majority of patients are diagnosed on the screening test that we do, the 50-gram OGTT screening test. Again, the confirmatory test here is going to be the 3-hour 100-gram OGTT. If the plasma glucose level is more than 125 milligram per deciliter at the beginning of the test, which means fasting blood glucose, this is diabetes mellitus actually, is going to be diagnosed. That's not gestational diabetes. An abnormal plasma glucose measurements is going to be more than 140 milligram per deciliter at 3 hours. More than 155 milligram per deciliter at 2 hours, and more than 180 gram per deciliter at 1 hour. So again, at the first hour it's going to be 180, and then it drops to 155, and then it drops to 140. If only one post-glucose load measurement is abnormal, let's say, this is going to be the diagnosis of an impaired glucose tolerance, which is different from gestational diabetes or diabetes in general. If 2 or more of the post-glucose load measurements are abnormal, this is the gestational diabetes here. The 1 hour 50-gram OGTT is a sensitive test, really. It must catch all patients that may have disease. The 3-hour 100-gram OGTT test is the specific one here. It must catch all the people that actually have the disease. So this is specificity versus sensitivity here. That's been the gestational diabetes. Now, at the end, we have a side note here related to the Rh or D immunoglobulin in Rh negative mothers at 28 weeks gestations. We give the Rh-D immunoglobulins here at that time, and this is 28 weeks. If we test at 28 weeks, and the Rh is still negative, we give the Rh-D immunoglobulin within 72 hours of delivery. We give it after miscarriage or abortion. We give it during amniocentesis or CVS. And we give it with heavy vaginal bleeding at any point. So those are the conditions that we give the Rh-D immunoglobulins here. Now, finally, let's talk about nausea and vomiting during pregnancy. It says that the following antiemetics can be used safely to relieve nausea and vomiting during the first trimester. The list includes doxylamine, metoclopramide, ondansetron, promethazine, and pyridoxine, which is the vitamin B6 here. So those are the list of the things that we can use in the first trimester here. Okay? All right, and on this note, I'm going to end at page 422. And next, we're going to talk about the third trimester bleeding. So stay tuned for that, and I'll see you in the next one. All right, bye-bye.